So this is about malaria testing. Okay. Now, what are the tests you know of malaria? Malaria, we think that we know lots, but we probably don't know. We need to understand what this is all about, and you need to understand the whole thing, because these are things that as anesthetists, as just MBBS doctors, you might not know. Okay. Malaria. How is malaria tested? What is the gold standard?
Gold standard is peripheral smear.
Yes. Now, when you say peripheral smear, what are the smears that you know of?
Thick smear.
Thick smear and thin smear. So there are two kinds of smears. It's called thick smear and it is thin smear. And what is the information you can get from these thick smears and thin smears? What is the difference between both of them? What do you get as a difference between both of them? Why thick and thin? You said two smears. You said thick and thin. Why?
One for organism, one for load of the total load.
No. So thick smears means you diagnose malaria. You just diagnose because there is malaria. You just diagnose. Thin smears is you speciate. You say this is malaria vivax, malaria ovale, plasmodium falciparum, malaria knowlesi. There are different kinds of malaria that we know of. We speciate them because we have a difference in the treatment. We have a difference in the severity. Falciparum malaria is supposed to be more severe than plasmodium malaria. Though we know that even plasmodium malaria can become severe, but we know falciparum malaria has got its own changes. Plasmodium falciparum will have a different dosage schedule when it comes to the treatment of long term, whereas plasmodium malaria vivax will have a different kind of treatment. What is the different treatment?
Primaquine 7.5 mg BD for 14 days in vivax. Falciparum 45 mg stat dose.
What is the difference between both? किसमें क्या हो रहा है? Why are we? What is the difference between both? Why are we giving this primaquine?
Recurrence chances is more in vivax, na?
But why are we? So what about in falciparum malaria?
Generally, it does not recur, no sir. Hepatic.
Then why giving primaquine?
Hepatic phase एक है उसके.
Why are we giving primaquine if that's the case? If it's not recurring, why? So there are two different things. Plasmodium falciparum is for the gametocyte, whereas for vivax is for the hypnozoids. So in malaria, what happens? There are hypnozoids which are living in your liver, and later on will come back and things like that. All this. So you give primaquine at a dose of 7.5 milligrams twice a day, to these patients. Whereas when you look at falciparum malaria, you're looking at gametocytes. Okay, what will happen is today she has falciparum malaria. If that mosquito goes and bites her and then comes and bites you, she is not going to have a problem, you are going to have the problem. So the gameto for falciparum for the next patient it is not for this patient. You are understanding? It is so that it doesn't go to the next patient. For example, if I have 4 patients in the ICU with falciparum malaria, the next patient can get it. Very simple. If a mosquito bites them. So there are ICUs in our country where if the patient gets falciparum, they put the net. Seriously, I'm telling you, करते हो लोग, करते हैं. Because where there is a huge prevalence of malaria, they do all these things because patients die. They don't have hi-fi ventilators, they don't have blood banks, they don't have a lot of things. नहीं है उनके पास, नहीं है तो नहीं है, but they are doing these things. They put mosquito nets. I've gone to an ICU where they put mosquito net. Why? Because simple है ना, यहाँ से काट के उसको जाके काटेगा. उसको काटेगा तो उसको भी मलेरिया हो जाएगा. You understand? So I hope you remember this, that if you have a person with falciparum malaria, you must be careful to give him the dose quickly in the first or second day of primaquine. That's why you need to know the species. You need to know the species of malaria that you are having, whether it's malaria, whether it's vivax, okay. So peripheral smear, and it also gives you a very important feature called as parasitic index. Now, what does a parasitic index tell you? Parasitic index tell you how severe this thing is. Okay, so sometimes what does happen is, if your parasitic index is alarmingly high and patient is just not improving, then we want to remove those parasites. And to remove those parasites, there's only one technique. Do exchange transfusion. Remove the blood, put in new blood. This is not being proven in adults. It has been still proven in neonates. In neonates and pediatrics. In adults, we are not certain, though I did one exchange transfusion in the past. In the past, I have done one exchange transfusion. But I don't think that it is really evidence-based in adults per se. Okay, and you normally at this given moment you are not seeing such cases. Why? Because the moment the patient comes, patient gets artesunate, patient gets the fancy go, patient gets Numirax. At home only they get it. So the actual entire parasitic index actually comes down. We don't see only such cases. Very rare to see parasitic index more than 10%. When I say high, it means more than 10%.
That Lumerex we gave,
Sorry?
Lumerex, dosing like the different dosing.
So we'll come to that. Before we come to that, let's come to the diagnosis first. So what is how do you diagnose this? So एक हो गया peripheral smear. So that means what do you require for a peripheral smear? You need to take the blood. You need a good microbiologist. Okay. And you need to see at least 50 of these parasitized RBCs per microliter. That is a usual amount. In the country, we say he is a good microbiologist only if you can see around 100. 100 का detection हो रहा है उसका. 100 parasitized RBC में detection हो रहा है means he is a good microbiologist. But a good microbiologist, extremely good microbiologist can see 50. 50 में भी दिख जाएगा उसको. 50 में भी उसको दिख जाएगा. Okay. Remember this. To create fever, you need at least 50. 2 या 3 parasitized RBC से कुछ नहीं होने वाला है. To create pyrogenic nature, to create fever, you need at least how much?
50.
Actually, you need above 50, maybe around 100. That's why the government has put a regulation that this microbiologist should see at least 100. That means he'll pick up them if there is fever. So, is there a point of sending malaria without fever? No, na? No. If there is no fever, why are you sending malaria? You understand what I'm saying? There is no point of sending malaria because we want to detect the parasite, and the parasite detect only when the pyrogen is released, and that will occur only when the parasitic index is higher or when the number of parasites are higher. So there is no point of sending malaria when the patient is not having fever in the first place. Right? So what is the other test that we do here? You said peripheral smear, and we now understand what is the difference between thick and thin smear. What is the other test to do? What is RMAT?
Rapid malaria antigen test.
What is this test? How is this test done?
Prick test.
हाँ.
It is a normal prick test.
हाँ.
Rapid kit आता है.
हाँ.
उसमें check.
What is it checking?
Antigen against malarial antigen.
Which
Antibody
malaria?
against.
So, but you normally when you take a rapid malaria, you get an answer, no? Vivax है, falciparum है. तो फिर कैसे आ रहा है?
CBC भी फॉर्मेट करते हैं.
हाँ? Time नहीं है. Well tried. Next. Yeah, try. He's well tried. He thought this is the time. It's not the time. Next.
Number of
One और lines रहते हैं.
Lines.
तो
हाँ, एक आंसर आ गया. Line आ गया. फिर. So you should know what they are testing. What is the antigen that you are testing. जब हम RT-PCR कर रहे थे, हम COVID-19 PCR antigen कर रहे थे ना. We were saying ये spike आ गया, वो spike आ गया. So that is the similar technology here also. They are looking at the antigen. And the antigen is called as histone-rich protein (HRP). Huh? That is a histidine-rich protein or histone-rich protein. Okay, HRP. Okay, this is what they are looking at, HRP. So there are 3 things that are seen. There are 2 things rather to be seen. There are actually 3 things: Plasmodium LDH, Plasmodium aldolase, and Plasmodium HRP2. HRP2. These are the 3 things that are seen: Plasmodium LDH, Plasmodium aldolase, and Plasmodium HRP2. So the card that they're using is a small card. It's like a pregnancy kit. Okay, it's a small card. It's a very small card which has got lines. Okay, so they take the buffer, they take the blood, they put that inside the well. There's a well there. एक well में डालते, दूसरे well में डाल देते, एक में buffer डालते, एक में blood डाल देते. And then this, look at the lines that are coming. If one line comes, the control, that means the test is okay. Okay, and then dependent on the number of lines you have, you are said, okay, this is falciparum, or this is Vivax, or this is a combination. So it's a card test. Okay, what is the card test we're using in our hospital? Paramax 3. The name of the card test is Paramax 3. Okay, it's called as Paramax 3. That's the card test that we're using. It's called Paramax 3. Okay, which is actually finding out LDH, the speciation, as well as it tells you whether it's falciparum or it is Vivax malaria. It is actually telling you this. It cannot tell you whether there is malaria or there is knowledge. It cannot tell you that. इसलिए हमको दिखता नहीं है. समझ रहे हो? उसके हमको दिखता नहीं है वो. You understand what I'm saying? हाँ, it tells you about Vivax, it tells you about falciparum. Here, treatment. Artesunate. How many days?
For 3 to 5 days.
Minimum 3 days.
What is the treatment? Artesunate. How much is the dose of artesunate? Wait, hold on. Artesunate dose?
2.5.
No, one second. Huh?
2.5.
No.
2.4 mg.
Full dose,
2.4 mg per kg, 0 hour, 12 hour, then 24 hour, then 1 IC for 3 days.
So this is the dose. The dose is 0.24 milligram per kilogram, 0, 12, 24. You can't change the dose. If you don't know the dose, it's very dangerous. 2.4 milligram per kilogram, 0, 12, 24. It has to be done like that. There is no other way to do malaria. 0, 12, 24 if the patient cannot take oral. The moment the patient starts oral, you can convert to oral combination therapy, which includes a combination of maybe artemether and lumefantrine, or artemether and atopinon, or sulfadoxine, paramethamine. Some you can take some combination that is there. It always has to be in combination. It always has to be in combination. Okay, it reduces resistance pattern and causes recrudescence to reduce. No recrudescence will occur. How many days do you give it? Say a patient is there with malaria and 4th day, 5th day patient is still not okay. What will you do?
Admit patient.
How many days? Will you increase it? 7 days, 10 days, 14 days, 21 days? How many days?
Continuous.
7
No.
days.
So as far as possible, you'll have to stop by 5 to 7 days. 5 days is what is required. Why? Because it actually takes care of the malaria life cycle. You understand? एक बार वो चालू कर देते, in 2 life cycles it finishes off everything. That means in the 3rd dose patient is okay. In the 3rd dose, 2 life cycles, 3rd dose patient is okay. मतलब 2 asexual life cycles of the parasite खत्म होते हैं, उसके अंदर उसका locked reduction इतना हो जाता है कि patient is okay. Are you understanding? Huh?
So then if the patient doesn't get better,
Then there is some other cause for this.
okay.
There's some other cause for this. Yeah, because that's why malaria is such a good simple treatment to do, right? That's why malaria is such a simple treatment to do. You just give it, it becomes fine. If it still persists, it's not malaria. There's something more here. If a dengue fever goes on for 7 days, it's not dengue, it's something else. Dengue fever cannot continue for 7 days. Dengue fever will stop at 3rd to 4th day and then become afebrile. If it goes to 7 days, this is not dengue, there is something else. Some secondary infection. You can't be bitten again and again because you become second time resistant. Once you get dengue, you get an antibody. You're not going to be again having dengue fever again. वापस dengue हो गया 4 दिन के अंदर. ऐसा नहीं होता है. कल भी मैंने dengue था, 4 दिन के वापस dengue हो गया मेरे को. Fever गया वापस आया नहीं, ऐसा नहीं है. So dengue comes with that kind of pattern where you have fever, absence of fever, fever, absence of fever, fever. This is dengue characteristic.
Godrej hospital we had a patient, old lady,
ले लो फोन को.
presented after 3 days with rash. He admitted her, she was dengue positive. Then later she had fever again, and she had this conjunctival
Suppression.
She came leptospirosis.
So what happens is, unfortunately, is you do rapid malaria and you do sometimes you do this IgM dengue, IgG dengue. No, IgM remains positive for some months, 3 months. IgM can be positive for 3 months. IgG can be positive for life. IgG can be possible for life. You know, in IgM dengue, if you don't have a clinical manifestation, you can't rule it as dengue. You can't rule it as dengue. NS1 remains only for 5 to 7 days. So you can do NS1 for 5 to 7 days. That will give you a better idea whether there is dengue NS1. That is dengue going on as of now. You understand? So IgM dengue, it should be interpreted in a clinical feature, and you should look for dengue NS1 at that particular moment. That's why IgM dengue can be positive for 3 months also. Very often malaria and dengue is positive. You think of treating dengue and then malaria comes, leptospira comes positive, or dengue, something else comes positive. Okay, these tests of malaria are very, very sensitive. They will pick up, they will say this negative very well. Okay, they are known to detect less than 10 raised to less than 50 colony forming units. It comes positive. You understand? Less than 50 colony forming units it will detect. So there is a possibility you will detect it here, but you will not detect it in the peripheral smear, because it can detect even 4 or 5 also. You understand? Clear?
So one.
That's it. ठीक है.